Hi guys, this is your favorite series with Ask the Doc and Dr. Ren. Dr. Ren, thanks for having us back.
No, glad to be here.
We got some good questions this time around, right?
Yeah.
From all around the world. So you know what? We actually have one from an actual doctor from Switzerland. You tell me, right? Correct?
Yeah, I read here. He says he's a 49-year-old doc from Switzerland, he's a doc where he lives in Switzerland. I don't know if he's actually from there, but anyway, yeah, good question too.
So you want to read that one because there's a lot of tests and jargon I don't get.
Well, he says, and he doesn't leave his name, but that's okay. Hello, sir. I'm a 49-year-old doctor from Switzerland where I live, and saw my hematocrit at 65 approximately. They took out a half liter of blood times 3, and first time replaced the half liter with, I guess, normal saline, looks like, and found out that I have what he calls the Vasquez disease, which he says in parentheses, my EPO doubles my red blood cells from the protein. I think he means, he's saying JAK2. Anyway, it's a JAK2 gene mutation that causes this. He takes 500 milligrams of hydroxyurea, which is a cancer drug, and 100 milligrams of aspirin, I assume daily. My question is, what kind of steroids can I take that don't inflate too much? I'm sorry to translate here the English. In reproducing his red blood cells, not equipoise and not a long ester type of testosterone like cypionate. My doctor, blood specialist, doesn't know anything about steroids, SARMs, or HGH. Can I take primobolan, anavar, testosterone, phenylpropionate, and HGH? I'm an American bodybuilder, so please don't say don't take steroids anymore. It's my reason of life. I guess reason for living. I stopped steroids for the past 6 months. Please help me and maybe save my life. You're a good-hearted guy. I trust you. God bless you, sir. Very nice of you. Thank you for your question. You know, a lot of patients come in asking about elevated hemoglobin and hematocrit because their doctors have always said, and you know, Dr. Google included, or anything on the internet, you know, if you take testosterone, you're going to get elevated hemoglobin and hematocrit, which isn't necessarily true. I don't know the physiologic mechanism by which that would be true, meaning just adding testosterone to the body per se, and your hemoglobin and hematocrit going up directly because of that. If that were the case, think about it. Then every 16-year-old to 25-year-old would have elevated H&H and elevated red blood cell count. It's a problem because it confounds this gentleman's issue, and I don't mean to go too far afield, but just for educational purposes, which is why we're doing this, right? The problem is typically when I see patients in their testosterone replacement days, they've got sleep apnea. So basically they're training in their sleep, I call it. They're going into oxygen debt, which sets the process in motion where the body then reacts and says, hey, we got to make some more oxygen carrying capacity, more trucks to deliver, and bigger bed in the truck, more red blood cells, more hemoglobin, the carrier, the bed in the truck, to get the oxygen from the lungs to where it needs to go. And, well, testosterone helps leverage that process, and I choose the word carefully. It doesn't make it happen, meaning in and of itself. There has to be something going on that testosterone can leverage. I mean, there's a reason why, let's say, I don't want to pick on any sport because it'll get taken the wrong way, but there's a reason why cyclists, for example, who are happy being 6'5", 135 pounds, want to use testosterone to help their performance, because it's not just making muscle, it's also leveraging this process. So if somebody has sleep apnea prior to getting on testosterone replacement therapy, starts taking it, then all of a sudden you can see the effect. You see the elevated hemoglobin, hematocrit, and red blood cell count typically, and you go, oh, great. We can we've identified, it's now more easily identified, besides the usual things like, your spouse says that they can't get to sleep or stay asleep at night because you're snoring so loud, or you wake up gasping for air or anxious for no apparent reason. Anyway, in the case of this gentleman, they've identified a JAK2 gene mutation, which means that, in essence, your body is making more hemoglobin and hematocrit just because. And in this case, again, because his testosterone levels are raised to presumably optimum levels, it shows itself more than it normally would. So in this case, he's taking a cancer drug normally used for leukemia, but I have to be honest, I haven't heard of this treatment for what would be referred to as polycythemia rubra before, but I suppose it's something they are using anyway in Switzerland. But he's asking, what else can I do, I think, to, I'm going to say what else you can do. One of the things I do for any case like this is, other than therapeutic phlebotomies on a regular basis, we want to stop the formation somehow of excess hemoglobin and hematocrit. Well, hemoglobin, hemi, requires iron. So I tell some of these patients, hey, certainly don't take iron supplements. Avoid sources of iron as best you can. So at some point, you'll deplete your iron stores and you won't be able to produce excess hemoglobin and hematocrit. I had one patient with a JAK2 gene mutation, and I got to tell you, in my history of doing this, I can name maybe 12 patients that have been identified with a JAK2 gene mutation. So it's not that frequent. But, excuse me, one patient went to his hematologist, who I got a hold of, and we got to discuss things back and forth, and he actually made a very good point. We don't have any proof of it, but the idea was, look, this is left up to the patient. As long as there's no harm, in other words, it should be left up to the patient that, hey, this is just going to be a pain in the rear end, having to get serial phlebotomies. But the hematologist said, yeah, but you're forgetting about one thing. We have to keep digging into bone marrow stores, right, to create more and more of these cells. Are we essentially burning out the blood marrow, the bone marrow, excuse me? And it's a good point. I don't know. I don't know of any studies. I looked him up, and he was of the same mindset. He doesn't have any studies either, but it does make sense, doesn't it? So with someone with a JAK2 gene mutation, you wonder, do you want to go to that extent, or do you want to keep furthering this issue to the point where you might be taxing effectively your longevity, because you're tapping into your bone marrow, your stem cells? I would argue that we do actually have a way around that. You could use stem cell replacement. You could use, in other words, exogenous stem cells. We can get them from fat now very, very easily. So fat-derived mesenchymal stem cells could be used to replenish the presumed depletion of the stem cells. But anyway, just side note. So I'm sorry. Back to his question. What steroids? I apologize, and I'll go back and do a little homework, and maybe we'll tag this on something else, the next videos. But I'm not aware that a longer ester would necessarily make a difference. The issue is, if the testosterone is there, it's going to leverage this. So I'm not really sure what the question is. If you're using a longer ester, well, then you just have to dose less frequently to keep the testosterone there. But the whole idea is, in order to feel better and all the other reasons why he's taking this, you want to have the testosterone around, or anabolic steroid around, in place, if you will. So a shorter ester, excuse me, we had the heater on last night, and, first time in a while, so I got a dry throat, but a shorter ester is just going to mean more frequent dosing. I'm not sure what the implication would be to use a shorter ester and somehow make this less of a problem. Certainly, to avoid potential problems, which I've never seen, by the way, with blood viscosity. I had a fellow with an autoimmune disorder that made his hemoglobin and hematocrit go up very, very high, so that I saw a hemoglobin of 26, I swear, and I think the associated hematocrit would be like a 78. He got phlebotomies on a regular basis, sometimes every week, to control it when it was flaring up. But he never stroked out. He's still alive and well and works out at our gym. You've probably seen him. So while taking aspirin would theoretically be a good thing, certainly to help the platelets from being sticky, and maybe some other blood thinner would be a good thing. I think more to the point is, what can you excuse me, what can you do to keep taking testosterone replacement, or in this case anabolic steroids, and avoid the elevation? Again, not let it have the building materials it needs, and the most important one I can think of is iron. So if we can limit the iron, then I think you'll be okay. As far as human growth hormone, to my knowledge, it should not affect your JAK2 gene mutation or the production of any more red blood cells. It's not going to affect that mechanism that starts with the kidney, goes to the bone marrow, and is part of that creation. So that should be helpful. I don't think you need to eliminate growth hormone, but again, I don't know if I gave you much information, except I guess the biggest question is, how can you keep that from going high? I would limit your iron. I guess that's the gem there to take away. The rest of it is just hopefully educational for some people.
Very cool. Thank you, Dr. Bear.
No, my pleasure.